So we'll move on to the next speaker, which is Karim Wahbi from Paris. And Karim is a specialist for the heart involvement in patients with muscular dystrophy. So the perfect person to talk to.
So we move on now to the French accent. So as Volker said, I'm a cardiologist by training. I'm running a cardiomyopathy center in Paris. And I'm really glad to make this presentation today, and I will happy to any discussion with you after my talk. So roughly 1/2 of patients with LGMD2I will be diagnosed at some point with cardiac abnormalities. And unfortunately, sometimes cardiac involvement can result in impaired quality of life due to shortness of breath as a consequence of heart failure. And also sometimes a small proportion of patients will develop terminal heart failure, which represents a significant cause of death in this condition. And sometimes patients can also have heart transplant. So that's the reason why an early diagnosis and an early treatment of cardiac abnormalities are extremely important. The most common abnormality which can be diagnosed is dilated cardiomyopathy. Dilated cardiomyopathy is a manifestation characterized by an involvement of the cardiac muscle, more specifically the left ventricle, which is the most important cardiac muscle, whose contractility, whose strength may be progressively reduced. And to measure that in clinical practice, we use a parameter called the ejection fraction that can be measured on the echo or on MRI. And when you have an ejection fraction of below 50%, then you can be diagnosed with dilated cardiomyopathy. And generally, the cardiac function can decline progressively in parallel with the increase of the burden of fibrosis at the myocardial level. The normal cardiac tissue can be progressively replaced with a scar, what we call fibrosis. And at some point, heart failure can be a consequence of dilated cardiomyopathy, and it can be a major problem. In cardiomyopathies in general, we can sometimes also see electrical abnormalities, but they are not so common in LGMD2I dilated cardiomyopathy. But sometimes you can have palpitations mainly related to premature ventricular contractions. But generally, they are not severe. As I told you, cardiac abnormalities generally develop progressively over years. And importantly, cardiac involvement can be present even in the absence of any symptom, especially in non-ambulant patients. And sometimes a cardiac complication can be the first manifestation of the disease. That's the reason why it's extremely important to have diagnostic procedures done systematically, even in the absence of symptoms, because sometimes you can find significant abnormalities even when there are absolutely no heart failure manifestations. I told you that approximately 1/2 of patients can have cardiac involvement. In most studies which have been published so far, we had a prevalence of dilated cardiomyopathy of approximately 40%, but over lifespan, it's obviously more. And some other patients can have fibrosis diagnosed, especially on MRI, without having a dilated cardiomyopathy diagnosis. The prevalence of cardiac abnormalities and dilated cardiomyopathy increases progressively with age. And on average, dilated cardiomyopathy is diagnosed around the age of 30 years. We know that homozygous patients have less severe outcomes regarding the heart. They are generally diagnosed with dilated cardiomyopathy between, on average, 35 and 40 years. And in heterozygous patient, the age of dilated cardiomyopathy diagnosis is younger. Globally, the level of risk for cardiac complications is significantly higher in males. We discussed that yesterday, and this is something quite common in genetic and inherited cardiomyopathies. So we know that cardiac involvement is relatively frequent. We know that it can have an impact on long-term prognosis, so it's very important to have it diagnosed as early as possible in order to initiate cardioprotective treatments which have the potential to limit the progression of the disease. And for the diagnosis of cardiac abnormalities, two most important examinations we have are the ECG and the echocardiogram. The echocardiogram is non-invasive, non-painful, and it provides the majority of information you need to choose the most appropriate strategy for treatment and for follow-up. So the most important message is that ECG and echocardiogram have to be done at diagnosis and to be repeated over lifetime. Some other workups can have an added value, but it has not been validated, fully validated yet. It could be useful to have heart failure biomarkers tested in the blood, such as BNP, NT-proBNP. It can be useful to have a Holter ECG done when there's evidence of cardiac dysfunction for the diagnosis of arrhythmias. And MRI can also have the potential to offer the possibility to diagnose earlier cardiac involvement, because cardiac MRI can identify myocardial fibrosis, which cannot be seen on the echo. So the real added value of cardiac MRI compared to echo can be discussed. All experts do not completely agree on that point, but there's a potential with MRI possibly to diagnose cardiac involvement earlier. But I repeat, the most important message is that ECG and echo repeated on a regular basis are the most important things to do. As I told you, the paradigm for the diagnosis is to have an early diagnosis to initiate early treatments, because the earlier you treat, the more efficient you are to limit the progression of the disease. So I think it's important at diagnosis to have an ECG, an echo, perhaps a blood test, which can be easily implemented. And at some point, if feasible, perhaps a cardiac MRI as well, and a Holter ECG when there's evidence of cardiac dysfunction. And the echo has to be repeated every year to every 2 years. It depends on whether there are symptoms or whether initial assessments have been normal or not. So it has to be discussed on an individual basis. And I think it remains really unclear how often other assessments, such as MRI, should be repeated. So in the end, the main purpose is to have abnormalities diagnosed early, to have treatments initiated early. We have a number of treatments available for heart failure, which have been initially developed in the general population, which can be used to treat FKRP cardiomyopathy. The most commonly used one is ACE inhibitors. And we know from studies conducted in other neuromuscular conditions, such as Duchenne muscular dystrophy, that ACE inhibitors initiated early have the potential to limit the progression of the disease and to improve long-term prognosis. So very basically, we, as clinicians, we can identify several clinical situations. The first one is when there are absolutely no symptoms, no heart failure symptoms, and all the assessments done are normal. So in that case, there is no indication, no current indication to initiate a treatment. Unfortunately, sometimes we can identify heart failure symptoms and diagnose dilated cardiomyopathy on the echo or on MRI. And in that case, we need to use all the treatments available for heart failure. And now we have 4 to 5 medications with the potential to limit the progression of the disease. And then sometimes we can identify sub-abnormalities on the echo or on MRI, which can be asymptomatic, especially for patients who have lost ambulation. And I think it's not always consensual in the cardiology community to treat at this stage. But I think one important message is that regarding what has been previously shown in other neuromuscular conditions, such as Duchenne muscular dystrophy, I think it's important where there's evidence of cardiac involvement, even at early stages, probably to initiate treatments such as ACE inhibitors. It will be really difficult to validate or to demonstrate in studies, but I think we have really a strong rationale to recommend such approaches, especially, as I mentioned, studies conducted in DMD like this one a few years ago. And unfortunately, in the event of advanced severe heart failure, we have sometimes difficult decisions to make. Very generally, in patients who have genetic cardiomyopathies of any cause, when the ejection fraction is severely reduced below 35%, we discuss the implantation of a cardiac defibrillator, which is a device we put under the skin, whose objective is to treat severe arrhythmias that may occur and that may be responsible for cardiac arrest. So there's a global recommendation in inherited cardiomyopathies to use this treatment. But I think there is no clear consensus on the indication of such devices in very rare conditions such as LGMD2I. And the indications had really to be discussed on an individual basis in order to be sure not to cause more harm than benefit, because the implantation can be challenging, especially when there's respiratory failure and there may be complications following the implantation of the device. So it really has something that needs to be discussed between the neurologist and the cardiologist, and sometimes the pneumologist. And sometimes, when the ejection fraction drops even below 35%, some patients may develop a terminal heart failure, and we know that some patients underwent successfully heart transplantation. It may be feasible, but sometimes it's difficult when there's respiratory failure, because having a cardiac surgery can be really challenging with a high risk of complications. So an alternative to heart transplantation, which has been used in some cases, can be the implantation of what you call a left ventricular assist device, which is a cardiac pump that can represent an alternative to cardiac transplantation. It's not always feasible, but sometimes this option can be discussed. So in conclusion, I think the main messages are, firstly, to have a cardiac follow-up on a regular basis with at least an echo. It must be repeatedly every 1 to 2 years, and to initiate cardioprotective treatments at the moment when cardiac involvement can be identified, even with mild abnormalities. Thank you for your attention.